We will continue with prostate cancer part 24, treatment of metastatic M1 castration-resistant prostate cancer. Treatment option for castration-resistance castration should be continued while other cancer therapies are administered. Retrospective data suggests that the continuing castration in the CRBC improve overall survival. Quantify the metastatic burdens. High volume metastasis defined as a high having at least one visceral non-node metastasis and or more than or equal 4 bone metastases with at least one bone metastasis not in the vertebral bodies or pelvic bone. Low metastatic burden is defined as absence of visceral metastasis. That's known as low metastasis. Any number of the nodal metastases in any of the following, that's no bone metastasis, 1 to 4 bone metastases in any distributions, or more than or equal 4 metastases that are all confined to the vertebral bodies and pelvis. Patients with symptomatic metastasis, especially bone pain, have worse overall survival. When bone metastases are present, consider treatment with zoledronic acid or denosumab to prevent skeletal-related events. The androgen receptor spine variant 7 is under normal circumstances, androgen stimulation is controlled by androgen receptor signaling pathway, which is triggered when androgen bind to certain domain on the normal androgen receptors. Some prostate cancer treatment depended on androgen receptor signaling pathway to exert their anti-cancer effect, known as androgen receptor signaling pathway dependent therapies. These therapies include medication that lower the androgen, such as abiraterone, and medication that inhibit the binding of androgen to the androgen receptor, such as enzalutamide. The androgen receptor's variant protein is an abnormal androgen receptor. It blocks androgen binding domain. Therefore, it does not bind to androgen and does not participate in the normal androgen receptor signaling pathway. However, it still stimulates androgen effect in the tissue, including the cancer growth. Because androgen receptor variant 7 is not involved in the normal androgen receptor signaling pathway, it's continuous to stimulate the cancer growth in the presence of therapy that exerts the anti-cancer effect through the ASRB. In fact, ASRB dependent such as abiraterone and enzalutamide are less effective than in presence of androgen receptor variant 7. Therapies that do not depend on the androgen receptor signaling pathway, such as cytotoxic chemotherapy, are generally not affected by presence of androgen receptor variant 7. When androgen receptor variant 7 positive, mean that is present, men treated with taxane chemotherapy have better progression-free and overall survival than men treated with enzalutamide or abiraterone. When androgen receptor variant 7 is negative, it means that androgen receptor variant 7 is absent. Most studies show that similar progression-free and overall survival whether the patient was treated with enzalutamide, abiraterone, or taxane chemotherapy. In men with metastatic CRBC, androgen receptor variant 7 was present in only 3% of men who had not been treated with enzalutamide, abiraterone, or taxane chemotherapy, but was present in 19 to 38% of men who had already been treated with and progressed on either enzalutamide or abiraterone. Testing for androgen receptor variant 7 might most useful in men with metastatic CRPC who have progressed on the ARSP-dependent therapy such as enzalutamide or abiraterone, because these men are more likely to have ARV7. If ARV7 is present, then chemotherapy will be more effective than switching a different ARSP-dependent therapy. Testing for androgen receptor variant 7 mutation is typically accomplished by examining circulating tumor cells. Sequence of therapy for CRPC prostate cancer. For CRPC, castration should be continued while other cancer therapies are administered. Retrospective data suggests that continuing castration in CRPC improves overall survival. This is Taylor, 1993. When specific therapy other than castration fails to control CRPC, then consider switching to the therapy that has a different mechanism of action than the previous therapies. Limited data suggests that abiraterone followed by enzalutamide might result in less PSA progression than enzalutamide followed by abiraterone. Androgen synthesis inhibitors and anti-androgen are less effective in the presence of androgen receptor variant 7. If androgen receptor variant 7 is present, consider using therapy that has different mechanism of action than androgen synthesis inhibitor and anti-androgen such as docetaxel. Treatment and prevention of bone metastasis. A skeletal-related event is usually defined as bone fracture, spinal cord compression, or bone conditions that require radiation or surgery. Pathological fracture in men receiving anti-androgen deprivation have been correlated with decreased overall survival. Approximately 50% of men with CRPC and untreated bone metastasis will develop SRE within 2 years. That's known as skeletal-related events. So approximately 50% of those men with CRPC, castration-resistant prostate cancer, and untreated bone metastasis will develop skeletal-related events within 2 years. The incidence of skeletal-related events in population can be reduced significantly by treating with osteoclast inhibitor like zoledronic acids or denosumab. This is known as osteoclast inhibitor that reduce the incidence of skeletal-related event. Bone reabsorption, resorption is a process by which osteoclasts catalyze the bone and release minerals, including calcium, into the blood. In the normal condition, bone is constantly remodeled through a balance of bone formation by osteoblasts and bone resorption by osteoclasts. Receptor activator of nuclear factor Kb is a receptor on the surface of osteoclast rank ligands. A protein produced by osteoblast is one of the key regulators of remodeling. When rank ligand binds to the rank receptor, osteoclasts are stimulated to resorb breakdown bone. When cancer metastasizes to bone, the cancer often secretes mediators that alter the balance of the local bone remodeling. For example, cancer can stimulate an increase in rank ligand production. This increase in rank ligand causes osteoclast overactivity, resulting in excessive bone resorption. Excessive bone resorption releases growth factors that stimulate cancer growth. Cancer growth further stimulates rank ligand production. This endless cycle of tumor growth and bone resorption weakness the bone and increase the risk of skeletal-related events. Denosumab and bisphosphonates such as zoldronic acids are both osteoclast inhibitor. However, the mechanism by which they inhibit the osteoclast is different. That the denosumab and bisphosphonates or bisphosphonates such as zoldronic acid are both osteoclast inhibitor. Treatment of bone metastasis. For bone metastasis with castration-sensitive metastatic prostate cancer, start androgen deprivation with medical or surgical castration. Start zoldronic acids or denosumab to prevent or delay skeletal-related event. For bone metastasis, castration-resistant metastatic prostate cancer, continue castration. Start zoldronic acids or denosumab to prevent or delay skeletal-related events. Painful bone metastasis. Focal bone metastasis might be treated with external beam radiation, which eliminating bone pain in 25 to 40% of the cases and improve bone pain in 80% of the cases. So eliminate the bone pain by 25 to 40% and improve the bone pain 80%. For non-vertebral bone pain metastasis, the dose for non-vertebral bone metastasis, the dose is 8 gray per lesion, delivered in single fraction. Diffuse bone metastasis might be treated with chemotherapy or bone-seeking radionuclides. Diffuse bone metastasis might be treated with chemotherapy or bone-seeking radionuclide. Significant threat of fracture in a weight-bearing bone usually require orthopedic surgery. Pathological fracture usually require orthopedic surgery. We'll come to medications such as the bisphosphonate or bisphosphonates. Zoldronic acid is known as Zometa. This is the trade name, Zometa, 4 milligram. Zoldronic acid is a bisphosphonate, a compound that has two phosphonate groups. Bisphosphonates bind to the calcium. Since the largest store of the calcium in the skeletons, bisphosphonates concentrate in bone. Mechanism of action: zoldronic acids prevent bone resorption, breakdown of bone by inhibiting osteoclast activity. Zoldronic acid is FDA approved to prevent skeletal-related event in patients with castration-resistant prostate cancer and bone metastasis. In men with CRPC and bone metastasis, zoldronic acid significantly reduces skeletal-related event and delay the onset of the skeletal-related event by nearly 6 months compared to placebo, but it does not improve overall survival. It significantly reduces pathological fracture, might reduce spinal cord compression and the need for bone radiation, but this trend did not reach statistical significance. Prior to the therapy, perform routine oral examination. Consider obtaining dental examination and preventive dentistry for patients with poor oral hygiene, periodontal disease, dental implant, oral trauma, like poor fitting dentures, recent dental oral surgery, example dental extraction, steroid use, and other risk factors that might increase osteonecrosis of the jaw. Those in men with creatinine clearance more than 60 ml per minute, zoledronic acid 4 mg IV infused over no less than 15 minutes every 3 to 4 weeks. For use in men with a creatinine clearance less than or equal 60 ml per minute, you can see the description. During the therapy, administered at least 500 milligram calcium and 400 international vitamin D3 orally each day. The optimal duration of therapy is not known, but the mean duration of treatment in a study is approximately 9 months. Side effect of zoledronic acid, most common side effects are anemia, dyspnea, flu-like symptoms like fever, chills, and fatigue, weakness, arthralgia, bone pain, gastrointestinal symptoms such as nausea, vomiting, constipation, diarrhea. Zoledronic acid can cause renal insufficiency in 17%, anemia in 33%, neutropenia in 12%, thrombocytopenia in 10%, and hypocalcemia in 1%, hypophosphatemia less than 12%, hypomagnesemia in 1%. So hypocalcemia, hypomagnesemia in 1%. Remember, neutropenia and hypophosphatemia in less than 12%. Thrombocytopenia 10%, but the most common anemia with zoledronic acid, and the second common is renal insufficiency 17%. This is the side effect. Other rare side effects reported in bisphosphonates include osteonecrosis of the jaw, severe bone, joint, or muscle pain relieved by stopping the therapy, atypical subtrochanteric and diaphyseal femoral fracture, ocular inflammation, uveitis, scleritis. During therapy, obtain serum creatinine before each dose. Monitor calcium, phosphate, magnesium, creatinine during the therapy. It also be burden to monitor CBC. Monitor for symptom of osteonecrosis of the jaw, pain, numbness, jaw and mouth swelling, and femoral fracture, thigh or groin pain. Maintenance of good oral hygiene and preventive dentistry are recommended during the therapy. Invasive dental procedures should be avoided during treatment. We come to the denosumab, 120 milligram, or known as Xgeva or Xgeva. This is denosumab, as is denosumab, bisphosphonates, pterygium, all these osteoclast precursors, multinucleated osteoclast, activated osteoclast, and this is osteoclast cell. So as you see, this color here is denosumab. The mechanism of action of denosumab is to stop or inhibit osteoclast activity. This is the denosumab. The dose is 60 milligram per ml. Denosumab 120 milligram. So it's two doses of this equal 120 milligram subcutaneous injection every 4 weeks is FDA approved to prevent skeletal related events in patients with bone metastasis from solid tumor, including prostate cancer. At a lower dose and frequent 60 milligram subcutaneous injection every 6 months. It's FDA approved to increase bone mass in men at high risk for fracture who are receiving androgen deprivation for non-metastatic prostate cancer. Mechanism of action of denosumab is a monoclonal antibody that binds to rank ligands and prevent it from activating the RANK receptor. Therefore, denosumab prevent bone resorption by inhibiting osteoclast activity. In men with CRBC and bone metastasis, denosumab is 120 milligram reduce skeletal-related events and delay the onset of skeletal-related events. In men with skeletal-related event, with castration-resistant prostate cancer and no bone metastasis, denosumab 120 milligram delay the development of the bone metastasis but does not improve overall survival. Smith et al. 2011 randomized men with non-metastatic CRBC who had PSA more than 88 nanogram per ml and or PSA doubling time less than or equal 10 months to placebo and denosumab of 120 milligrams subcutaneous injection every 4 weeks. Denosumab 120 milligrams significantly delay the onset of the bone metastasis by the median of 4.2 months compared to placebo. Both groups have a similar overall survival. So far, the FDA has not approved denosumab for prevention of bone metastasis. A randomized trial comparing zoledronic acids and denosumab in men with CRBC and bone metastasis showed that the following result. Time of skeletal-related events was significantly longer for denosumab by median of 3.6 months compared to the zoledronic acids, but the rate of various skeletal-related events were similar. In other words, skeletal-related events were equally likely to occur, but the onset of skeletal-related events was later in men receiving denosumab. Hypocalcemia occurs significantly more often with denosumab, 13% versus 6%. So hypocalcemia significantly occurs with denosumab, 13%. Osteonecrosis of the jaw was slightly more common with denosumab, 2% compared with zoledronic acid 1%. Also, the difference was not statistically significant. Denosumab caused less acute phase reaction than zoledronic acid. Acute phase reaction produce flu-like symptoms such as fever, chill, arthralgia, bone pain, fatigue, typically within 3 days of treatment. There was no difference in overall survival or progression-free survival between the denosumab and zoledronic acid. Other difference between denosumab and zoledronic acid, denosumab is subcutaneous injection while zoledronic acid is intravenous injection. Denosumab is not eliminated by the kidney and it is not nephrotoxic. Thus, it does not require monitoring for renal function or dose adjustment for renal insufficiency. Zoledronic is eliminated by the kidney and can be nephrotoxic, thus it requires monitoring of the renal function and dose adjustment for the renal insufficiency. Prior to treatment, check the calcium level and correct hypocalcemia, perform routine oral examination. Dental examination and appropriate preventive dentistry should consider in patients with poor oral hygiene, periodontal disease, dental implant, oral trauma such as from fitting dentures, and also recent dental or oral surgery such as dental extraction, steroid use, and also other risk factors that might increase osteonecrosis of the jaw. Those prevent skeletal-related event in patients with bone metastasis from solid tumors. Denosumab 120 milligrams subcutaneous injection in upper thigh, upper arm or abdomen every 4 weeks with oral administration of calcium and vitamin. Calcium 1000 milligram daily, vitamin D3 more than or equal 400 IU daily. Side effect, the most common side effect were fatigue, weakness, nausea, hypophosphatemia. Denosumab 120 milligram cause severe hypocalcemia in 3% of the patient. Patient on dialysis with creatinine clearance less than 30 milligram per minute may have high risk of hypocalcemia. Denosumab 120 to 120 milligram dose cause severe hypophosphatemia in 15% of patients. Denosumab 120 milligram rarely cause osteonecrosis of the jaw, but the risk of increase with duration of therapy risk is 1.1 during the first years, 3 to 4% during the second years, and 4 to 7% per year thereafter. So 1.1 in the first year, 3 to 4% during second year, and 4 to 7% per year thereafter. During therapy, monitor calcium phosphate level in all patients. In addition, consider monitoring magnesium in patients with renal insufficiency. Monitor for symptoms of osteonecrosis of the jaw, pain, numbness, or swelling in the jaw, or inside the mouth. Maintenance of the good oral hygiene and preventive density are recommended during therapy. Invasive dental procedures should be avoided during treatment with denosumab 120 milligram. Bone seeking radionuclides, B-particle emitters. B-particle emitters deliver radiation to bone metastases, resulting in reduction in cancer-related bone pain, known as P-particle emitters, B emitters, deliver radiation to the bone metastasis, resulting in reduction in cancer-related bone pain. These agents are used mainly for men with painful bone metastases that are numerous enough to make external beam radiation impractical. Example of P emitters include strontium and samromium. This is the P emitters. P emitters improve cancer-related bone pain in approximately 50% of men and eliminate bone pain in 10% of men. However, up to 25% of men will have initial increase in pain, a pain flare. B emitters do not improve survival and reduce skeletal-related events. Bone marrow suppression is major dose-limiting toxicity. The most common side effect is thrombocytopenia. Of B emitters, thrombocytopenia is common. Bone-seeking radionuclides, that's A particle emirates. So A particle emirate like radium-223, known as Zovogo or Zovogo. This is a trademark of radium-223. Radium is radioactive. A particle or alpha particles emitting element that kill tumor cell by creating double strand break in the DNA. Radium-223 has several properties that make it particularly suitable for treating bone metastases. Radium-223 mimic calcium radium, and calcium have a similar chemical behavior because they are in the same group of elements on the periodic table. Like calcium, radium is taken up into area of increased bone metabolism. This radium is most effective in osteoblast lesions. Alpha particle emitter radiation travel a very short distance, less than 100 micron. Therefore, it can kill nearby cancer cell with minimal damage to surrounding normal tissue. Radium-223 is FDA approved for the treatment of men with castration-resistant prostate cancer and symptomatic bone metastasis, but without visceral metastasis. Patient with malignant lymphadenopathy more than or equal 3 cm in size were excluded from the trials. Thus, radium-223 is not recommended in men with malignant lymphadenopathy more than or equal 3 cm in size. Radium is the only bone-targeted therapy that improves overall survival in men with metastatic CRPC. Radium usually does not reduce the PSA. The LSIMBACA trial randomized 921 men with CRPC, no visceral metastasis, and more than equal 2 bone metastasis to the placebo or radium-223. Radium significantly improved the median overall survival by 3.6 months, delay the onset of skeletal-related events by a median of approximately 5 months, including pathological fracture, spinal cord compression, need for bone radiation, improve quality of life, and reduce bone pain. Side effects were similar between radium and placebo. Side effects were similar between radium and placebo. The common side effects include nausea, vomiting, diarrhea, and peripheral edema. Radium rarely causes significant thrombocytopenia, neutropenia, or anemia. Obtain CBC before each dose. If significant myelosuppression is present, radium should be discontinued. Dose of radium-223 55 kbq per kg body mass IV every 4 weeks for 6 doses. Do not co-administer radium with chemotherapy because of cumulative myelosuppression or with Ebrotron because of increased fracture and mortality. Castration, bisphosphonates, and denosumab can be co-administered with radium and do not reduce the risk, does not reduce the efficacy of the radium. This is a comparison treatment of the bone metastasis in men with CRPC. As you see, reduce skeletal-related event, which that's statistically significant clinical effect. Zoledronic acids and denosumabs, beta emitters, radium-223. All this it will lead to reduce skeletal-related events except beta emitters, and all this medication also lead to delay onset of skeletal-related event except beta emitters. Delay pathological fracture, yes, zoledronic acids, it will lead, and radium also, it will lead to delay pathological bone fracture. The beta emitters is not, and denosumab is also not known. Delay spinal cord compression, zoledronic acid, it is not. A delay was observed but did not reach the statistical significance here. But yes, radium-223, it lead to delay spinal cord compression, as well as delay need for bone radiation, as well as delay ECOG BS deterioration, and also as well as improve quality of life and also improve overall survival. Radium-223, it will lead to all this function, and the beta emitters, it is not lead to all these functions, but only it reduce bone pain. This is the beta emitters, and might be improve quality of life. This is the beta emitters. Denosumabs, yes, it reduce delay of skeletal-related event and also delay onset of the skeletal-related event, and also it reduce bone pain, and it is not improve overall survival, but might improve quality of life. The zoledronic acids, yes, it is reduce delay skeletal-related event as well as onset of skeletal-related event, and also delay pathological fracture as radium, and also it reduce bone pain, but it is not do other function like delay pathological, delay spinal cord compression, or delay need for bone radiation, or delay ECOG, BS deterioration, or delay improve quality of life, or all this is not with zoledronic acid. Okay, thank you very much. This is the end of 24.